Hello friends. So today we'll be discussing about anorectal malformations. Before starting, I would like to thank Chandana Shri Ma'am for sharing these wonderful notes with us, which are very helpful for quick revision. And the link of the notes is given below. You can download it from there. So without further delay, let's get started. Anorectal malformation. So by definition, it's a spectrum of congenital malformation, congenital disorder, where the anus fails to open normally into the perineum. So the anus will not open into the perineum the way it opens and will be affected. Maybe it is opening somewhere else, it is not opening at all. So that are the possibilities. Now coming to the embryological basis, the urorectal septum moves caudally to divide the cloaca into anterior urogenital sinus and the posterior anorectum. Failure of this septum to form results in fistula between the bowel, that is vagina, or the urinary tract. Complete partial failure of this anal membrane, that is the part of cloacal membrane to absorb, causes anal membrane stenosis or imperforate anus. So this is the diagram of the same of what we discussed, that the advancing urorectal septum advances ahead and the urogenital sinus and the anorectal area is formed, and it advances to form the urogenital pathway and the rectal pathway. Anteriorly is the urogenital membrane, posteriorly is the anal membrane divided from the cloacal membrane. So what are the types of anorectal malformation? So we have wing spread international classification that divides into high, intermediate and low anal malformations, and is again divided into male and female due to different organs in the pelvis. So we'll see one by one. That is in males, where we'll have urinary bladder anteriorly and rectum posteriorly. So high, so it will be better if we can start it from high rectal malformation. So there will be rectal agenesis, where here the rectum ends in the supralevator region. So levator ani muscles, the rectum ends above that. So rectal agenesis with fistula between the rectum and the vesicle, that is bladder, or rectoprostate. So rectoprostatic. So these will be formed, or there could be rectal agenesis without fistula formation, that is rectal atresia. Then in intermediate, rectum ends within the levator. So there will be rectobulbar fistula or anal agenesis without fistula. In low, rectum ends infralevator, where there will be perineal fistula, that is anocutaneous or anal stenosis. We'll see them in diagram. In females, the high anorectal deformity will be anorectal agenesis with fistula in the rectovaginal region or without fistula, or rectal atresia. In intermediate one, hello. So in intermediate one, the rectovaginal fistula or rectovestibular fistula or anal agenesis without fistula. In low anomalies, there will be anovestibular fistula, anterior ectopic anus, that is anocutaneous, or anal stenosis. So these are the classification. Other classification we have is the Penna classification. In males with fistula, there could be rectovesical fistula, rectourethral fistula in the prostate or bulbar, or perineal fistula. Without fistula, there could be imperforate anus without fistula and rectal atresia. In female, without fistula is same, that is imperforate anus without fistula and rectal atresia. With fistula, there is persistent cloaca with less than 3 cm common channel or more than 3 cm common channel, vestibular fistula or perineal fistula. Now we'll see all these in diagram. So in males or in females, the perineal fistula, where it opens, usually associated with the median bar, that is bucket handle, and here it opens along the tip of the median bar, and it may open on either side of the median bar, and the region is distal rectum, is partially surrounded by sphincter complex. So as you can see in the diagram, here the perineal fistula, the anus opens downwards but is not having proper sphincter complex. As in this case, there will be proper sphincter complex, and here in perineal fistula it will not be having proper sphincter complex. Then coming to rectobulbar fistula, where there is the relatively long common wall between the urethra and rectum. Voluntary sphincters are well developed and visible pit at the anal side. So rectobulbar fistula, we can see here rectobulbar fistula, which opens in the bulbar area of the urethra. Anus opens into the bulbar area of the urethra, and there will be pit at the anal side. Then rectovesical fistula, where it opens into the bladder, and common wall is small, and there will be associated sacral deformity and very poor voluntary sphincter complex. Again, we have similar is the rectoprostatic fistula, where the sphincter is more hypoplastic. There will be sacral deformity and the rectum opens into the prostatic urethra. And with no fistula, here is the diagram of rectoprostatic fistula and rectovesical fistula. Then comes with no fistula, that is anorectal anomaly without fistula. So rectum ends blindly, well formed anal pit, and there will be well developed voluntary sphincters is associated with Down syndrome. And rectal atresia, where there will be secondary to intrauterine vascular accident, normally looking anus ending blindly above the dentate line, and normal volunteer sphincter muscles will be formed, and proximal blind bowel connected to the blind ending anus by short distance of fibrous tissue or membrane. So there will be rectal atresia. So as we can see in the diagram, the imperforate anus, there will be anal pit and blind ending of rectum, and in case of rectal atresia, there will be rectum which is connected to the anus with help of fibrous tissue or a membrane, and the sphincters will be well developed. This is common in both genders, rectal atresia and imperforate anus. Now we see some disorders, that is the perineal fistula in females. That is when the rectum opens between the anal side and the vestibule without the median bar. It is more anterior fistula opening not into the sphincter complex, and perineal groove between the outlet and the vestibule. So as we can see in the diagram, this is the normal anatomy where the anus opens in the sphincter complex and vagina opens into the vestibule. So if these goes anteriorly near the vestibule, then it will be perineal fistula or anterior perineal anus. So this was when the rectum anus opens towards the vestibule or is just behind the vestibule. So perineal fistula, anterior perineal sinus. In anterior perineal sinus, it is moderately stenotic anus situated anteriorly just behind the vestibule, and normal sphincter posterolaterally, poor sphincter anteriorly. So anteriorly there will be deficiency of sphincter function. Then rectovestibular fistula, where the rectum opens directly in the posterior fourchette of the fistula behind the hymen, and 2 to 4 centimeter common wall, well developed voluntary sphincters associated with vaginal anomalies. So that is a possibility. So this is anovestibular fistula, which completely opens into vestibule. Then we have rectovaginal fistula, which is very rare, where the rectum enters and opens into the vagina, and then the cloaca, where common channel for urinary vagina and rectum, which is length of 1 to 5 centimeter and can drain anywhere between, but most commonly in the posterior vagina, inferior posterior vagina. And long common channel with poor sphincter formation can be associated with obstructive urological disorder and Mullerian anomalies and sacral anomalies. So this is the cloaca, where there is common opening as you can see in the diagram, and there is poor sphincter mechanism. Sacral anomaly is also there. And here is the rectovaginal, where the rectum opens into vagina, but it is very rare. So this was the diagrammatic representation and explanation for these disorders. Now we see the epidemiology. So it is seen in 1 in 500 births, and male are more commonly affected up to 60% times and have severe malformations than females. And these can be associated with syndromes and non-syndromes also. So what are these? They are Vactrel, Klippel-Feil syndrome, trisomy 21, 13 and 18, that is Downs, Patau and Edwards. Then cat's eye syndrome, Hirschsprung disease and Opic syndrome. Associated anomalies will be urogenital anomalies, skeletal anomaly, GI anomalies, cardiovascular anomalies, CNS anomaly. Overall association will be 65%. Then we go for evaluation, detailed physical examination of the perineum. Then we have to rule out associated anomaly. What we go is sacrum USG, spine and sacrum USG, renal ultrasound, urine analysis, and rule out tracheoesophageal fistula, 2D echo. We go for all this. Then we go for invertogram, which will help us in detecting the anomaly, the level of anomaly. Then after we go for there is important aspect, that is Murugusu technique, that in sitting position needle is introduced into the rectal pouch and meconium is aspirated. If meconium is found, contrast is injected and X-ray is taken. That will show us whether the what is the level of defect. And we also go for cross table radiograph along with perineal USG, CT and MRI for sphincter anatomy. If there is rectal gas distal to coccyx and the patient is stable with no other significant anomaly, we go for PSARP without any, with or without covering stoma. So what is PSRP? That is posterior sagittal anorectoplasty. We'll see it in detail. Then if there is rectal gas proximal to the coccyx, so it is above rectal atresia with more than 1 centimeter gap, and there is presence of meconium in urine, that is rectourethral or rectovesical fistula, anomaly of sacrum or flat bottom, or there could even be vestibular fistula. Then we go for colostomy, that is end colostomy with mucous fistula, and that too with sigmoid or descending colon. And later with the distal colostogram we go for delineating distal anatomy, and later we'll go for reconstruction. So after the initial investigation and going between the X-ray, we wait for 18 to 24 hours so that the rectum is collapsed and false high ARM is not missed. Now coming to the definitive surgical procedure, in case of low anorectal malformation ARM, we go for incision of the anal membrane, anovestibuloplasty or anoplasty, along with anal dilatation, that will be helpful. Then PSARP, that is posterior sagittal anorectoplasty, which is commonly done when the rectal gas is below the coccyx, so it's a low ARM, mid ARM. Then PSRBUP, that is in females posterior sagittal anorectovaginourethroplasty, and TUM, that is total urogenital mobilization. So in males, in perineal fistula, we go for minimal PSARP. In rectourethral fistula, we go for PSARP. In rectovesical, we go for PSRP along with laparotomy for reconstruction. In anorectal anomaly without fistula, we again go for PSARP, and rectal atresia, we go for PSARP. In females, in perineal fistula, we go for limited PSRP, same in anterior perineal anus. And Similarly in rectovestibular fistula, again limited PSARP, and in cloaca we go for PSAR-VUP, that is vaginourethroplasty, along with laparotomy and total urogenital mobilization. Then coming to PSARP for some details, that is in PSARP we determine the sphincter location by electrical stimulation. Posterior midline incision is given from saccix to anal pit, coccyx to anal pit, identifying and dividing fistula, mobilizing the rectum, anoplasty, and followed by serial anal dilatation. So this is the most common surgery that is performed and is useful for most of the anorectal malformations. So this was all about anorectal malformation. Keep studying, keep growing. Thank you for watching, and never give up because great things take time. See you soon in next video, and please like, share and subscribe. Thank you.